Hello, I'm Sharon with Nurse Tim, and I'd like to thank you for joining us for our webinar, Next Generation of NCLEX, Applying Clinical Judgment in the Classroom, featuring Karen Sherrill. We will have technical assistance available at 866-861-2896, option 1, or help at nursetim.com. Handouts are available to download on the right side of your screen. Please note, handouts are for personal use only and are not to be distributed to others. Our archive listeners are encouraged to drop us an email or give us a call. We welcome your questions and value your input as to desired topics for future webinars. ANCC disclosures. NCPD. This webinar has been awarded one Nursing Continuing Professional Development Contact Hour by Nurse Tim Incorporated. Nurse Tim Inc. is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. Successful completion. Criteria for judging successful completion of the webinar are attendance at the entire activity and submission of a completed evaluation. Expiration date. Archived activities must be completed and evaluations submitted within 30 days of accessing from the Nurse Tim Inc. website. For more information, contact help at nursetim.com. Learning outcomes. 1. Review research that supports the use of clinical judgment in teaching. 2. Explore the progression of integrating clinical judgment decision-making in students. 3. Compare several activities that apply clinical judgment development. Throughout this activity, the speaker may use a variety of real and varied resources from health education vendors. They are for illustrative purposes and are not to endorse any product. All images and references to the NCSBN Next Generation NCLEX are the property of the National Council State Boards of Nursing and provided for teaching purposes only. And now I am pleased to introduce our speaker. Karen Sherrill is an experienced nurse educator with over 3 decades of teaching an associate degree in baccalaureate nursing programs. Her experiences, passions, and areas of expertise are broad. They include clinical judgment integration, next-gen NCLEX item development, active and scrambled classrooms, student success and remediation, pre-licensure testing, and simulation pedagogy. Karen has led several innovative projects in college, statewide, and national organizations to advance teaching and learning in nursing education. Karen enjoys serving on the board of directors for Haiti Kids School, which supports children's education in Leogane, Haiti. In her retirement, she enjoys traveling internationally and getting out of the hot Phoenix weather to escape the mountains to the mountains of Montana. We are so thrilled to have you with us today, Karen.
Thanks, Sharon, for that very warm introduction, and thanks to all you that are tuning in today. Whether you are listening to us live or via archive, we really appreciate you taking the time, and I recognize how time is so valuable as a nurse educator. So I'm hoping over this next hour, you're going to find some very valuable tools that you can take into your classroom that's going to make your life much easier. I am a huge proponent of working smarter, not harder. So here we go. I'm going to show you some ways to do that. So first of all, I got to start by asking a little question, and this is pretty easy. It's just 2 answer choices, but I want to know from you, which image best depicts the workday in a life of a nurse? Is it A, beginning of the day to the end of the day, or is it B, beginning of the day to the end of the day? And for those that are live, just go ahead and type that into the chat. I'd love to see your responses. Oh, what a surprise. Everybody thinks that B is a typical workday in the life of a nurse, and I would have to agree with you. In fact, all the years that I've been using this example, I've not yet had anybody select A. So as nurses, if you have worked even a single day as a nurse, you know that our days are never linear. They are not from the start to the end, but they are chaotic with lots of changes in decision making. And the reason I like to use this example is because I want to ask you, if we are preparing our students to go into a profession that functions like B, are you teaching A? Because if you're teaching A, you are not preparing your students for B. So, are we preparing our students like the olden days, like the way we learned? Are we preparing our students for an environment that doesn't exist? Or are we preparing our students for the reality of what they're going to be walking in today? And I hope you recognize is that what we need to do is change our way of thinking. The ways that we were taught how to be nurses is not preparing our students for the healthcare world that they're walking into. So our first polling question, and I would love for those that are watching live to go ahead and tune in and select your answer. Those that are listening via archive, I want you to reflect on this question and think about the answer that you would choose. So the question is, I consciously and consistently utilize an evidence-based clinical judgment model in my classroom, lab, simulation, and clinical teaching. So consciously and consistently use an evidence-based clinical judgment model. So let me give you a second to think about that and to select your answer. Okay, so I'm seeing kind of a split audience here, and quite a few of you say, yes, I do. A few others that say, no, I can't say that I do. But oftentimes when I ask, okay, what is that evidence-based clinical judgment model? Many times faculty will say the nursing process. Nursing process is my foundation. But know that the nursing process is not necessarily a clinical judgment model, but it is more of a critical thinking model. And we'll talk about a little bit about the ways in which they are different. So as you think about clinical judgment and the definition that was given to us by National Council of State Boards of Nursing through their research study was that clinical judgment is the observed outcome of critical thinking and decision making. So in order for us to observe somebody's outcome, we need to see somebody doing something, okay? So clinical judgment is doing, whereas critical thinking and decision-making is the thinking process taking place in our head. Knowing that clinical judgment is an observed outcome or doing, then it's measurable. We can see our students completing clinical judgment. We can see that process versus critical thinking, such as what we get with the nursing process, is the process of thinking that's happening within that student's head. It's also an iterative process, and iterative means it's repetitive. It means that it needs to be used consistently in order to make it a habit. I think back to ways in which I learned how to improve my clinical judgment and thinking as a new nurse. And one of the things that I was taught was a head-to-toe assessment. And we still teach our students that today. But know that a head-to-toe assessment is a consistent process, a repetitive process of thinking in order to make decisions about patient care. And still to this day, when I'm in a classroom and I'm asking students a question such as, okay, what findings will you discover for a patient who has condition X? And I literally will debrief my classroom using a head-to-toe functionality in my mind. I'll say, okay, what do you see neurologically? What do you see cardiovascular? What about respiratory? And I literally go through the pattern of head-to-toe because that is the process that I was taught. I also know that in nursing school, when I documented in the old-fashioned paper charts, we were taught SOAP notes and SOAPier notes and DAR notes and PI notes. That's a repetitive way of thinking. So there was a sequential process that was taking place in our minds that helped us to analyze our patient care. Students don't get these processes anymore. We teach head to toe, but then they go to the hospital and they see focused assessments. They might practice those head to toe in the lab, but they're not using them in practice. The whole process of DAR notes, PI notes, SOAP notes, SOAPier notes have gone by the wayside with electronic health records. We've got check boxes. So students have lost those iterative, repetitive processes of thinking that they need in order to build and develop clinical judgment. So as we look at the clinical judgment measurement model, and I'm sure most of you have seen this by now, I encourage, if this is brand new to you for the first time you're seeing this, you need to go to ncsbn.org and you need to look at Next Gen Project. You will find scads of newsletters, you will find lots of videos, and you should go there and you should review the information that has led up to this process and where we're at. So Layer 3 is where we're mostly focused. These are the main steps of the clinical judgment measurement model. You can see from this that they very much reflect a similar process to the nursing process. And the nursing process is at the bottom of the page. That was actually added to the model at a later point. But they have a lot of similarities in ways in which they progress through this thinking process to develop clinical judgment. Although they have a lot of similarities, in my mind, I also see them as different. So nursing process was originally developed actually in the 1950s, and it was thought of as a care plan model. It was a way in which to provide care for our patients so that we were incorporating some critical thinking. Nursing process is designed perfectly for that patient who needs to have a plan of care, and they need to be out of the hospital in 5 days. You know, my first nursing job was a med-surg flow, and we got the overflow, med-surg floor, we got the overflow for cataract surgeries and eye surgeries. So our cataract surgery patients were in the hospital for 7 days. That shows you how old I am. But with this beautiful nursing process and care plan, we got them out of the hospital in that amount of time beautifully without complications, because we had this wonderful nursing process planning model that guided our direction. What I see is different about the NCLEX clinical judgment measurement model is that it's a point of care decision-making model where our students and our nurses are making decisions at the point of care. It's not based upon this systemic problem of shortness of breath that the patient came in with because of their pneumonia, but it's based upon the fact that, oh my gosh, my patient is short of breath. That's strange. That wasn't happening before. What do I need to do about it? So it's a point of care decision-making model is how it can best be used. Many programs will ask, yeah, but do I even need to teach nursing process anymore? And what you need to think about is what's being utilized within your community. In some communities, nursing process is still an embedded piece of the care plans in the agencies. And if this is the case, then yeah, you still need to be teaching both, because you're sending new grads into an environment that is utilizing nursing process consistently. But I encourage you to think about ways that you can also be teaching your students point of care decision-making. And I'm going to give you lots of examples of activities and how it is that we're going to be developing that. So the layer 4 of the clinical judgment measurement model is where we're adding context to the test questions that National Council will be implementing. And really what they did through the process, they being National Council, did through the process of research is they recognized that people who apply clinical judgment, there are certain times that there's things that maybe skew their ability to make sound clinical judgment decisions. They categorize those into environmental factors and individual factors. And these components make a difference. They're kind of like things that come about that can change your ability to make clinical judgment decisions. You know, I think about this as I was a critical care nurse, and once upon a time in my career, I was pretty good critical care nurse, and I was very confident in my clinical judgment decision making. And you know, I give me anything, walking in the door, I can handle it because I was very experienced and I was very confident. But then there was the day that I would walk into the nursing unit and they'd say, oh, guess what, Karen, today you're getting floated to labor and delivery unit. And I would just have this blood curdling scream come out of my mouth, please don't let me go to the labor and delivery unit. It's a different culture in labor and delivery. It's different task complexities. It's different time pressure. It's different consequences and risks. It's a different environment. Everything that happened in that unit was so foreign to me that I didn't have the ability to make sound clinical judgment decisions. I lost my confidence and my competence in making clinical judgment decisions. In fact, I would beg and grovel with those nurses, say, please just let me take vital signs. That's all I can do. I'm going to take the best vital signs you've ever seen, but please don't make me take care of a patient. And I think you can probably relate to this story because we've all been there at some point in our career. So now to our second polling question. And the question here is, what is or are the most common reasons that a new grad loses his or her license in the first year of practice? Failure to notice, failure to act or respond, failure to communicate. And with this one, it's a select all that apply. So you can select 1, 2, or 3 answers. So I will give you a second on that. Those for archive, please reflect. What do you think the answer or answers are? Okay, looks like I got a bright group listening in today because you guys got it correct. All three are the correct answers. These are the top three reasons why a new grad loses their license in the first year of practice. And recognizing that failure to notice is recognizing cues. That's part of the clinical judgment measurement model. Failure to act or respond, that is part of generating solutions, prioritize hypothesis, and take action. Failure to communicate, again, that's that missing link of taking action. These are the reasons new grad lose their license. And this is information that is reported by National Council. I'd like to share this with my students, not to scare them, although it does scare them. I like them to be aware of why it is new grads most commonly lose their license, hoping that they will take and facilitate this information into becoming safer practitioners. So let's talk a minute about what has occurred in entry-level competency over the last many years, couple of decades, 3 decades actually. So as you look at the data and you look at the research that's been done evaluating entry-level competency of our new grads as they roll into practice, back in the 1990s, Del Bueno published a model of PBDS. You may have heard of it before, Performance-Based Development System. And what that was is a process in which very realistic scenarios were delivered to onboarding new nurses in the healthcare scene, and so that they could have their clinical judgment abilities be measured. And Del Bueno, through her work, started monitoring and measuring clinical judgment, decision-making, critical thinking for a couple of decades, for quite a long time. From 1990 to 2005, she published lots of information on this. What she found is about 30 to 35% of new grads met entry-level competencies. In 2017, Kavanaugh and Sweda published a follow-up report, and they're from the Cleveland Clinic, and they also evaluated onboarding processes of entry-level competency using the same PBDS model. And they found from 2011 to 2015, those numbers of competency in entering practice was down to 23%. Kavanaugh and Sharpneck repeated that in 2016 to 2020. They gathered data, published it in 21. From 16 to 20, they had 14%. And in fact, just in the start of the year 2020, year to date, at the time of the publication, the number was down to 9%. Keeping in mind that that was starting to occur right at the onset of COVID, so that certainly could have played some role, but recognize this consistent deterioration of competency into practice, to me, is it blows my mind. It absolutely blows my mind to look at our new grads and how poorly prepared they are for practice. This is certainly part of the reason why National Council is changing the way in which they are delivering the NCLEX exam. So I want you to stop and reflect for a second and think about each of these 3 questions. Do your expectations for students' clinical and classroom assignments facilitate clinical judgment? And I also want you to think, if your expectations require clinical judgment, think of an example. If your expectations do not require clinical judgment, what's missing in that process? And what's your aha moment? So I encourage you to actually jot these down. And I want to give you about a minute, full minute. I'm cutting you short here, but time pressure, we'll call this. But I want you to jot down answers to each of these 3 questions. So let me allow you time to do that. Okay, I hope that you had a chance to complete these 3 questions. If you didn't, I encourage you to continue reflecting upon this as we complete the webinar today, because I think it's really important for us to do some self-reflection and really think about, am I meeting and facilitating clinical judgment, or am I facilitating critical thinking, or am I not really doing either one? So again, how can we be more intentional with those decisions we're making in the classroom in order to strengthen our students' outcomes and their ability to think? So as we think about in the process of clinical judgment, and how does somebody learn clinical judgment, and what does a student look like as they progress in learning clinical judgment, I put these parts and pieces together as a way to show how do our students, what do they look like in the program as they progress through this learning process of obtaining a higher level of thinking? And I used novice to expert, which is Benner's model, as just kind of my headings for each of these categories, because I think that that's common terminology that we're fairly comfortable with. So certainly as we think about that novice student who does not have clinical judgment decision-making, they really are striving to gain baseline knowledge. And until somebody gains that baseline knowledge, they're not able to apply clinical judgment. It's important for them to have that foundation of baseline knowledge. And they start to, in these early stages, differentiate between normal and abnormal. So these are most of the time our first semester students, and many times this lasts usually about halfway through our first semester. I'd be concerned about a student who is still at the novice level by the end of their first semester. Probably not a student who's putting in enough time studying and understanding the baseline and memorizing some of the things that need to be understood, but really that foundational level. So as a student progresses to advanced beginner, and again, I'd like to see that by midway through the first semester into the second semester of the nursing program, they can start to identify cause and effect. They can recognize this happens because of this. They make associations between cues. So, if this is happening, then this should be happening, and they're going to start making those connections. They can differentiate between abnormal and critical. So it's more than just saying, oh, this is abnormal, or this one is abnormal, and that's really bad. That's really concerning abnormal. So they can start to make those differences, and they're starting to anticipate the needs of problems. So they're in those beginning stages of applying clinical judgment. The competent level student is proficient with cue recognition and analysis. And oftentimes, my main job for many years was third semester med-surg, and I had students who, when I would look at that clinical judgment measurement model of recognize cues and analyze cues, I would just merge them together, because my students in the classroom, I'd say, okay, tell me what cues we have in this case study. What do you see as cues? They would jump past recognizing the cues, and they would already be starting to analyze them. They had that level of competence that they were able to do that. So many times at this level, you might start seeing those first two steps of the clinical judgment measurement model starting to merge together, where they're not only recognized, but they're already analyzing those parts and pieces. The biggest struggle for students at that competent level is the process of prioritization. They don't understand prioritization. They're inconsistent with prioritization, and it's important for us to impress upon them what's your first priority, second priority, third priority. They constantly need to be putting things into prioritization order. I remember a student one time came into my test review and was going over a question with a student, and I said, tell me why you chose this answer, because the student really chose a horrible answer choice. And so posed it back to the student, tell me what you were thinking. Why did you select this particular answer? And the student's comment was, well, I selected it because it was the first bullet on the PowerPoint, so I figured it was most important. That's the kind of rationale our students have. So it's important for us to start getting them to think about, how do I prioritize, and what skills of prioritization can I apply? Students at the competent level also sometimes scramble to come up with differences between medical and nursing actions. The lines start to become skewed. Students at that novice level do a really good job knowing this is what a nurse can do, and this is what I need a doctor's order for. They're great at that. But at that competent level, they start to skew the lines because we do that to them. So I'll say in a class, is we have an example of a patient who's maybe deteriorating, and they're becoming short of breath and their blood pressure is dropping. And I'll say, oh, well, we need to adjust the head of the bed, and we need to open up the fluids, we need to apply oxygen, and we need to call the provider. And you'll do that sequence of a combination of nursing actions and medical actions all in the same sentence. And students don't necessarily recognize, oh, well, this one I can do on my own, and this one I can't do on my own. So we blur those lines for them, and it's important for students to start differentiating between those. And they also, at that confident level, can come up with adequate outcome measures. They know what an adequate outcome is. At that proficient level, and that's typically our students in their final semester, they're able to apply clinical judgment, but they often lack the confidence. They constantly want you to tell them whether or not they're right. They have the ability, but they don't trust themselves. But more importantly, and this is how we know we have created a safe practitioner, these students know when to seek guidance. I'm always more concerned about the student that doesn't know when to seek guidance. They have a false sense of confidence. They're moving forward with something that may or may not be correct. The expert level of clinical judgment decision-making is going to occur beyond graduation. First year of practice and as a nurse. And for some people, they develop clinical judgment within the first year, and other nurses don't. It takes longer than that. Where expert level clinical judgment is not something we're going to be seeing in our nursing students. So let's take a look at some activities related to the first step, recognizing and analyzing cues. So this activity is what I use with my students looking at direct and indirect cues. So when you're looking at the process of learning cue progression, you want students to not only start to identify the abnormal, but start thinking about everything related to that. So a first semester student, if you give them information that a potassium is 2.9, they are clearly going to say, ooh, that's abnormal. That number is really low. That's bad. That's a cue. But when you have a second semester student, what you want to do is not tell them what the potassium is, but simply say your patient takes a diuretic. And then the student will start to say, oh boy, if they take a diuretic, I probably should check a potassium level. So having your student come up with those indirect cues that are related to the information they have, start making those mental connections between what should I be looking for based upon the information I have. And that's how we are growing and progressing that process throughout the program. I also like to introduce students to what I call rapid and supporting cues. Rapid cue is the information that is most critical. What's most urgent? What do I have to address first? And I always like to tell students, what are you going to address first that you can do something about as a nurse? So if I give them some cues in a patient that has crackles, has a low urine output, has a low SpO2, and is on oxygen, what is my rapid cue? My rapid cue is SpO2 at 90%, because I, as a nurse, can do something about that. Crackles in their lungs, okay, I could probably do coughing, deep breathing, but I probably need some diuretics. We know this patient's in fluid overload because their urine output's down. But you know what? It takes doctor's orders to make that happen. But what can I do something about quickly? SpO2. I can raise the head of the bed. I can have that patient cough and deep breathe. I can potentially increase the oxygen if I've got an order to do so. So that SpO2 would be my greatest concern. Second scenario, platelets are 79,000, stools positive for blood, emesis of 150 mils of coffee grounds, and blood pressure 100/64. Which is my rapid cue? What can I do something about as a nurse? What do I want to address first? And in this scenario, it's the blood pressure. I can do something about that. I can position the patient, put the head of the bed down, turn them onto their side since they're vomiting coffee grounds, potentially adjust my fluid rate in order to improve that blood pressure. Keeping in mind that I don't want students to see a blood pressure of 80/50 because that makes the answer very obvious. 100/64 is not horrible for a lot of patients, and I want students to be able to say, could that be the answer, or is it something else? I want them to think more deeply and not automatically give them something that would be an obvious answer. The last scenario, blood alcohol is elevated, slurring of words, becoming belligerent. What's my first action going to be as a nurse? Well, I'm going to deal with that belligerence because I can provide some de-escalation techniques and prevent the situation from worsening. So what I do with this information after I have these quick activities in class, I can turn these into exam items. So I can say in an exam item, the nurse is caring for a client who comes to the emergency department with a blood alcohol level of 247, slurring words, and becoming belligerent. Which nursing action is the priority? And the answer choice would have to do with de-escalation techniques. So you can see that these little mini activities that are inserted into my class can provide great exam questions at a future point. And that's very fair testing because it's information you discussed in the classroom. This is a fun activity too. I call it Cue Cluster. I will give students just a variety of different cues. And what they have to do is figure out how they connect to each other. So for example, hypervolemia on the left-hand side of the page, you can connect that to the high heart rate. You can connect that to the high blood pressure. You can connect that to the crackles in the lungs. And it gives students the ability to think bigger. So when I hear the term hypervolemia, what else should I think about? I should think about heart rate. I should think about blood pressure. I could think about lung sounds. So it helps to build those pathways in analyzing the cue of hypervolemia or analyzing the cue of a low sodium level. So as students are working on this, either in pairs or in small groups throughout the course, once it's completed, it should look like this. They should have lines drawn everywhere. Now, the other thing about this is that it's chaotic. And we know that when we look at those context environmental cues, chaos is good. Remember the first question I asked you is a nurse's day linear? No, it's not. It's chaotic. So create activities in chaos. Don't just use linear outlines and bullet points and outline structure. You need to create chaos, and this is a great way to do it. This activity also works really well with medications. You could have a variety of medications, medication doses, medication side effects, and this is a fun activity to use for that. I also like students to think about actual and potential. So this is a very quick few sentences, not an extensive case study, but it's something I can put together literally thinking about in the car on the way to class that day. So a nurse is caring for an older adult client with dementia, fell at the care center, fracturing her right hip, placed on bed rest, orthopedic surgeon has been consulted, surgery is expected later this evening. She frequently yells out for her mother. I want you students to come up with 5 cues that indicate there's a concern. And those are actual things that I'm seeing there in that case that tell me that things are concerning. But now with the 5 cues of potential problems, I want you to identify 5 cues that I would see that indicate a problem. So if I've identified an actual problem of fracturing a hip and being on bed rest, that's a problem. But what are the cues? Well, most students would regurgitate what's in their textbook and they'd say, I'm worried about pressure injury. And pressure injury is not the answer I want. I want the cue of pressure injury. Pressure injury, what would it look like when a nurse sees it? So a reddened area on the coccyx, a reddened area on the heels, a reddened area on the elbows. That's the cue that the nurse looks for. If I'm worried about a pulmonary embolus in this patient or a fatty embolus in this patient, that's a problem. That comes out of my textbook, but what would a nurse see? Because I guarantee this patient is not suddenly going to have pulmonary embolism flashing across their forehead when the nurse walks in the room. The nurse needs to know exactly what they're going to see, and you want students to spell out the details of what they're going to be seeing. This is another activity for building cue recognition. I've got a patient who is 16, 35 weeks pregnant, insulin-dependent diabetic. She's been living in a shelter since her boyfriend physically abused her 2 weeks ago. Students are going to give me 10 specific cues that would indicate a concern. So a cue would be bruises on the arm. Cue would be the patient saying, I haven't felt the baby move in 2 days. Those are the cues that the nurse would see. That's what you need to extrapolate from your students. The other thing with this one that I like to point out is, if you think about the NCLEX exam and how few questions students can take in order to be a nurse, how does National Council do it? Well, here's a great example. This scenario right here, you've got a 16-year-old, which is technically pediatric content. You've got 35 weeks pregnant, there's your OB content. You've got insulin-dependent diabetic, there's your med-surg content. She lives in a shelter and physical abuse, there's your mental health content. So knowing that in this short case scenario, I'm covering a wide variety of topics. So this is a way in which those items are outlined in by National Council a lot of times in order to make sure our students have the appropriate level of applying clinical judgment. Love to give EHRs. And EHRs, without any patient information or diagnosis, in my mind, is one of the best ways to do it. So I would present students with these trends and data, and I would ask them to write a story. I would have them deeply analyze this information and come up with a patient scenario that would fit this information. Now, this is an activity I can do with my fundamental students because we just got them talking about normal and abnormal vital signs and things that cause vital signs to change, such as pain or pain medicine. So having students analyze this information is a great way for them to apply clinical judgment. The second step of the clinical judgment measurement model is prioritizing hypothesis. So how do we teach that? How do we progress the students in this process? Well, as students are learning the process of prioritization, they have to start with process of elimination, which means we give them lots and lots and lots of options, and they have to eliminate till they get to the priority option. As students get comfortable with this process of elimination for prioritization, we want to expose them to prioritization of several clients with complex data, information that are comparable to each other. So let me give you some examples of how to do these things. This is my unfolding prioritization case. These are my buddies, Greg, Marcia, Peter, Jan. Nurses caring for all four of them today. I have some very basic, simplistic information, and I want students to identify which of these four patients would you see first and why. Give them time to discuss. Give them, make sure that they rationalize the decisions they make. Don't tell them that there's one right answer. As soon as you tell them there's one right answer, they immediately will forget thinking about the others. I want them to share with me why they're thinking, because some of these patients are correct. Many of these patients are correct. More importantly, I want to know your rationale for why you chose them. After they've identified that, give them another layer of information, ask the same question. Now who's your priority? Who do you want to see first? And again, we can build this out as far as we want to build this out. It's unfolding cases, multiple patients, compare and contrast, constantly reprioritizing. This is what nurses do all day, every day, and our students should be doing it too. I also like to, in this last box, start thinking about how would I delegate? What could I delegate? What within each of these patient scenarios could I delegate to who? What would be a safe delegation, and have those discussions as well. Here's a comparison of 5 different clients, and they all have consistent information, but it's different. And once again, I want students to deeply analyze this data, and I want them to tell me which patient they would see first, which patient they'd see second, and which patient they would see third. And once again, they need to tell me their rationale as to why they made those decisions. Not a right and wrong answer. I just want to hear their rationale. It's also fun to do compare and contrast of the same disease process. So for example, when I talk about kidney stones, my friends Rachel, Ross, Monica, and Chandler come to class. And for each of these scenarios, I want students to identify each of these friends have a stone. Which of these patients would you see first? Who's your priority? Who do you see first? It also allows me to talk about different ways in which people respond to pain. Rachel and Monica both have pain of 10 out of 10, and look at the dramatic difference in how their body's adapting to that pain, and my vital signs are significantly different. So having those discussions is very valuable. The next couple of sections of the clinical judgment measurement model is generate solutions and take action. What are some activities that we can apply for our students to do this? Well, what I like to do with students is the progressive process throughout the semester. What I start with is what I call open brain, open book. That means an open brain means you can talk to your buddy. An open book means you can use all your resources. So if I give students maybe a case activity or a case study in class and I have them working on that, okay, this is going to be open brain, open book. Move forward, go with it. Then partway into the semester, I'm going to change it up and I'm going to say, okay, now you get open brain, closed book. That means you're going to work on this case study or this activity by talking to each other, but you're not going to use any of your resources. The reason why this is important is because when you give students a resource or say they can use resources, they simply copy down the information that's in front of them. They don't use their brain. They copy that big blue box that is in their book on page 455. So it's important for us to make sure that our students are progressing past that point and are in fact getting to the point of relying on their own minds. They need to rely on themselves on how to come up with those answers and get where they need to be at. As my students have become proficient in that, I actually move them to the next step, which is closed brain, closed book. That means no resources and no partner. And this is really where you see your strong students excel and your weak students plummet, because you will have students that will stare at a blank page of a case study. They cannot fill in the blanks or answer the questions because they have not properly prepared. They don't know the material. They don't understand the material, and they've been relying on somebody else to give them the answers. So this is a great way in which I will, as I walk through the room and I watch students work independently at trying to answer these case studies or activities, and I will look over shoulders and I will target students that are struggling, and I will ask them to come to my office because it's time for us to talk about your study habits and what it is you can do in order to become more successful in class. So it's a great type of formative evaluation for your students to identify who needs some additional resources, mentoring, and molding in order to be successful. This activity is really helping us to emphasize the difference between nursing solutions and medical solutions. So give your students a small snippet of data, and I love to work at EHR and tables and graphs because I know that next-gen trend items are going to be looking like this. So I want students to start analyzing data in this EHR format. So as the students are looking at these pieces of information, I want them to write down a list of nursing solutions and medical solutions. And I have them separate between the two because they need that differentiation. A few years ago, I had a good friend of mine who, a foolish girl, decided to go back to nursing school at the age of 50. And she has far more guts than I would have. I don't think I could do it again. But she went to nursing school, graduated, got her first job in a busy med-surg unit. She called me after about 3 or 4 months and she said, okay, Karen, I did it. I made my first medication error. I'm like, okay, Ann, tell me what happened. And she had a patient who was very nauseated. She had a whole fistful of pills to give the patient in the morning, and she knew that it was not going to end well if she tried to force her patient to take these oral medications. I'm thinking, okay, good. Good clinical judgment. That makes perfect sense. So what did you do? She said, I contacted pharmacy and I had them provide the medications IV rather than oral, and I went ahead and delivered them. She said, I know that's wrong. I know that now. At the time, it didn't come to my mind. I know that was an incorrect, it was a medication error, clear and simple. I needed a doctor's order to do that. But it didn't go through my mind that I needed a doctor's order. All I knew is that my patient could not take them orally. I needed to deliver them IV. And as I listened to her, I thought, you know what? I'm an instructor, and I have fed students that exact information, because what I've said to them in class is that if your patient's nauseated and they can't take their medications orally, you need to give them IV. I have not said if your patient's nauseated and they can't take their medications orally, you need to call the doctor and have them switch to IV before you deliver them. I've never said that. So as you can see, we are skewing those lines and creating unsafe practitioners by not having clear definitions between what is nursing and what is medical. So whenever I ask my students to make a list of actions, they need to separate nursing from medical. And sometimes it is obvious separation, like in this example, or sometimes I just have them put a little N or an M next to their list of nursing actions they're going to perform, so they know which ones require a doctor's order and which ones do not require a doctor's order. It's just safe for us to be reminding them of that. So what I can do is take that same information from the previous EHR that we saw, but now I have a list of actions. And what I want my students to do is I want them to decide what actions am I going to do within 5 minutes, within 30 minutes, within an hour, or not at all. So as you look at your EHR and the timing of 8:30, and I have this big long list of actions they came up with on the previous page, combination of nursing and medical actions, what are the most urgent that you need to do in 5 minutes? And which of those are unsafe that we don't need to do at all? And I'll have students complete this process of taking actions and, more importantly, prioritizing those actions. So they are identifying which of this big long list do I do now, what do I do later? Many times what our new grads are doing is that they get a list of doctor's orders and they simply complete them in sequential order. They need to know, I'm going to skip around on this list of doctor's prescriptions. I am going to do this first, then I'm going to do that second, then I'm going to do this third. They are not intended to be completed sequentially. So our students need to identify that. After I've got them into identifying the actions they're going to take in the first 5 minutes, then I will hone them in even more closely. Okay, what's first? Which of those 3 or 4 or 5 that you selected to do in the first 5 minutes, which one is first? Which one's second? Which one's third? Okay. This activity, great classroom activity, know that this can very quickly be turned into a next-gen item. And in fact, it fits perfectly with the grid matrix format. So I can take this activity out of the classroom, put it into an exam, and see if students retain the information that we discussed in class. So what is that last piece? What is that last section? Well, we want to be evaluating the outcomes. And what happens oftentimes, students will recognize that there is an outcome, and they'll say that's good enough, but they don't necessarily evaluate whether it's an adequate outcome. Is it an outcome that is sufficient, or is it an outcome that the nurse needs to do something more? So taking them through this algorithm and helping to identify, is that an adequate outcome or is it not an adequate outcome, is important. I think evaluating outcomes is probably the step of the nursing process or the clinical judgment measurement model that gets skated over the fastest. We don't spend a lot of time in teaching our students how to evaluate outcomes, and we need to be much more conscientious in that process. So have some practice examples in your class, and this is an activity I call thumbs up or thumbs down. Most of our students have thumbs, so it works well. You simply give me a thumbs up or a thumbs down as to whether or not this is an adequate outcome. So temperature change, 102.1 to 101.9, 15 minutes after acetaminophen, 650. Adequate, inadequate. Okay, I'm going to let you be the judge on that one. How about the same temperature change 1 hour after the medication? Adequate or inadequate? Well, at this point, we probably need to do something more from a nursing standpoint. The first one, I can sit on it. It's only been 15 minutes. Second one, I'm more concerned. So at this point, I'm going to cool down the room. I'm going to pull back the blankets. I might use some cool washcloths or some ice packs or a cooling blanket, whatever I need to do or decide to do. I'll also have students who look at this and say, I don't see what the big deal is. The temperature came down a whole degree. And this is where we go back to, let's read it again together and see what it is that's on the page. So students may not even see that it's only 0.2 of a degree. They might oftentimes say, oh, but look, it went from 102 to 101. Those are the students we concern ourselves with, right? How about client says chest pain is down to a 3 after nitroglycerin? If you are a cardiac nurse, you know that this is not a good answer because chest pain, we want to be at 0. But our students have just come from their med-surg surgical rotation, and pain of 3 is great when you have a post-surgical patient. So having those discussions of what an adequate outcome is. It might be an adequate outcome in one area, but it's not an adequate outcome in another area, depending on the patient scenario. Urine output of 100 mils 2 hours after diuretic, or what's a better outcome? What's a outcome that I can live with? Well, how about the crackles are gone 2 hours after the diuretic? That is a great outcome. Urine output increase of 100 mils 2 hours after, maybe not the best outcome I could have. The intention of the diuretic is to get rid of the crackles. The intention of diuretic is not to make the patient urinate, despite what students believe. So after we have taught our students each of these separate steps individually, and know that there's probably a reason why next-gen case is 6 items, and there's 6 items in the clinical judgment measurement model. I think that that's an important piece. So our students are going to need to know how to recognize cues. They're going to need to know how to prioritize hypotheses. They're going to need to know how to do each of these in isolation because they are going to get questions whose sole purpose is to evaluate that component of their critical thinking and clinical judgment. The thing is that there's also times when the student needs to put all of these pieces together, okay? Because there's going to be multiple parts of the clinical judgment measurement model layer 3 that they're going to be evaluated with. So how do we get our students to put all the pieces together? I told you already, I love EHRs. So I don't like to teach pharmacology. I prefer to teach MARS. So if I have a patient, I will design an appropriate MAR for that particular condition. And I have students analyze that MAR as if they're going into clinical. So I'll give you a second to look at this. And of course, I want you to be recognizing and analyzing cues. What information can you start to identify as a result of this? What solutions can you generate? What is there prioritizing hypothesis? What hypotheses can we make about this patient situation? Can we make determinations? So I'll give you a chance to think about that. Okay, what you've probably noticed is that the patient's likely diabetic. Patient likely has heart failure or maybe a atrial dysrhythmia, probably has some hypertension, maybe some GERD, but I'm a little concerned that aluminum hydroxide with meals, that's not typically how we prescribe it with GERD. It's usually a PRN. Multivitamin tells me they have some malnutrition. Okay, so I've made some conclusions. I've analyzed and I've prioritized some hypotheses about what should be going on. But I really can't generate solutions till I have some patient data. So after my students have analyzed this MAR, now I'm going to give them some patient data, okay? So now they are reanalyzing the information here, and what they've learned is that my patient is confused, disoriented, bradycardic, hypotensive, low urine output, and glucose is, it's okay. Could live with that for a diabetic patient. So now I want to ask my students, how to generate some solutions? How are you going to take action differently as a result of this information? And of course, I want my students to start thinking about holding the blood pressure medicine. I want them to think about holding the digoxin because my heart rate is low. I want them to think about what they would do differently based upon this information. And there's this scenario, and this is a great opportunity for you to have a really easy classroom activity, because how can I apply clinical judgment measurement model to this? I'm going to ask my students, okay, recognize some cues for me and analyze them. Okay, I want students to identify that the right foot is more swollen than the left. I want them to recognize that there's some sort of a ulcer or scar or something on that left little toe, which is concerning. And as they start to analyze, you're going to have students say things like, okay, maybe they're a diabetic. Okay, great. Let's talk about diabetes. Let's talk about perfusion. Let's talk about arterial and venous perfusion. Let's talk about what we would see or not see based upon arterial and venous perfusion. So how is the nail growth? How is the hair distribution? And if you're like me, I just want to reach down and touch those feet because I want to see if they're warm or cold. I want to check those dorsalis pedis and posterior tib pulses. I want to touch the feet. And have the discussions with your students. Okay, now that we have analyzed information, generate some hypotheses about what could be going on. I would want students to share things like maybe there's a DVT, maybe there's a knee or hip injury, maybe there's a blood perfusion problem somewhere upstream that's causing it. There's a wide variety of concerns that could cause this type of assessment finding. And so what are my solutions that a nurse should take? Well, a nurse should say, I want to decrease that edema, so I am going to elevate the foot. Okay, so now we are at take actions. We elevated the foot. So tell me what would be an adequate outcome. What would be appropriate? Well, I would want the edema to decrease. Perfect. How much? What would be acceptable by the end of your shift for the edema to decrease in this particular foot? So that is the line of discussion that you want to take your students through. And I tell you what, images are absolutely a great way in which to make that happen. Because you can apply so many steps of the clinical judgment measurement model, and you can bring that patient right to your classroom. Rather than giving students a bullet point PowerPoint slide, let's give them pictures of people so that they can start that evaluation process, start to recognize and identify what might be going on with that patient. So what else do I want to do putting it all together? Giving your students small case studies. Having them recognize, okay, what's important, what's not important. Make sure that your case studies are not all inclusive. I think we oftentimes feel like we have to feed the information to students, but as soon as we feed them the information, they're not coming up with questions in their own mind as to what to think about next. So what I prefer to do is unfolding case studies. So giving your students minimal amount of information and have them ask the questions about what's going to happen next. What else do I need to know? How am I going to care for this patient? Think about that patient who rolls in from the emergency department and you don't have any information other than what you collect. So don't give the students the entire health history of that patient until they're ready for that, and have them anticipate what that health history may be given upon the presenting symptoms that the patient's having. I also like to present cases with as many graphics as possible because I think seeing a patient's face really helps to bring realism to the case that you're presenting. So I encourage you to attach images as much as possible and make sure that they're realistic images. You know, little cutesy graphic cartoons are great, but I don't know that they increase the clinical judgment and ability for our students. So think of a difference in an image here if I had someone who was maybe looked very professional and neat and put together versus somebody who looked very disheveled and dirty. That is going to change my nursing care. And so it's important for us to start targeting the assessment skills with visual cues that we can give our students through images. Well, I think we have come to the end of the session, and I want to entertain, we've got just a couple minutes, but I want to entertain any questions that anybody would have. So I encourage you to type into the Q&A, and I will try to recognize some questions. If I can take one or two. Okay. So one question that I see, and I have to tell you this question comes up very commonly, but faculty want to know, how is it that I can do these kind of activities in my class but still get all my content in? And that is an age-old question. And it goes back to one of those early slides I had here about, are we teaching our students the way we were taught, or are we preparing our students for what they need? So what we have to learn to do as faculty is to let go of the way we've always been doing things. Consider the ability of taping some of your content material, putting together voiceover PowerPoints, putting them into your course management system, asking your students to complete those activities before they come to class, using your very valuable class time as 100% application. Strive for that, okay? That's the ultimate. And I have to tell you, that is the classroom that I've been running for probably the last 5 or 6 years. My outcomes have significantly improved as a result of it. I am 100% scrambled. I do not lecture anymore. All of that's available to students on their course management system. If that's not quite in your comfort zone yet, think about having one of these active, engaging activities embedded into your PowerPoint about once every 5 to 10 minutes. Expose your students to recognize cues, quick activity every 5 minutes. Expose your students to generate solution activity every 5 minutes. Start embedding those into what you're already doing. My guess is you probably have some PowerPoints you can probably get rid of. It might be information that's already being replicated in their textbooks that students can get from another location, but I challenge you to start thinking differently. We have got to mix it up in order for our students to be best prepared for the healthcare world that they're entering. So on that note, I am going to go ahead and turn control back over to Sharon so she can talk to you about your evaluations and wrap things up.
All right. Thank you so much, Karen, for your time today and all these great ideas and resources that you have shared. If anyone has additional questions for her, you can send us an email at help@nursetim. We'll put you in touch with Karen, or you can also fill out an evaluation and leave your valued feedback. We do review those, or ask any questions that you have. The evaluation also produces your certificate with your contact hour. And so I invite everyone to click that evaluation link on the right side of your screens. And thank you to everyone for joining us today.